Hello everyone. So welcome to you all our pediatrics university question answer discussion. So in this video we are going to discuss about the certain questions regarding the calcium. Usually, in our university exam, usually asked questions are short note as hypocalcemia in the children. Then another short note is hypercalcemia in the children. And if an essay is asked, it is asked describe the normal calcium metabolism, describe the causes, pathophysiology, clinical features, and management of the hypocalcemia in the children. So these are all the expected question patterns in the calcium related topics. So first of all, we have to learn about the calcium metabolism. So for that, we have to remember this picture in our mind. So the blood usually maintains a homeostasis for the blood calcium. That is, blood calcium level is about 10 milligram per 100 ml in our blood. So to maintain this, there are some mechanisms or hormonal mechanisms are activated. That is, if there is any decrease in the calcium level or if there is an increase in calcium level, the body tries to maintain this homeostasis by different hormonal mechanisms. First of all, we have to learn about the mechanisms. So first, the homeostasis for the blood calcium level is about 10 milligram per 100 ml. And so if there is any decrease or the fall in the blood calcium level happens, that act as a stimulus for the parathyroid gland. It is situated on the posterior aspect of the thyroid gland. And because of this stimulus, the parathyroid gland will produce the parathyroid hormone. And this parathyroid hormone that causes the increase in the blood calcium level by the different mechanism or by the different activation of different organs. So, because the stimulus is falling on the blood calcium level, so the parathyroid hormone which tries to increase the blood calcium level to the set point, and homeostasis for the blood calcium level is achieved. So the parathyroid hormone which attains this increase the homeostasis by different mechanism by activating the bond that stimulates the bond stimulates and calcium release from the bonds is happens, and also parathyroid hormone which also acts on the kidney and which stimulates the calcium 2 plus uptake in the kidney, and the kidney also which produces active vitamin D, and it also in turn which causes the increase the calcium 2 plus uptake in the intestine by three mechanism, by this bone resorption mechanism that causes the increase release from the calcium from the bone, then by the stimulation of calcium 2 plus uptake in the kidney, and also by the increased intake of the uptake of the calcium 2 plus in the intestines. By these three mechanisms, the parathyroid hormone tries to increase the blood calcium level in response to the stimulus, that is falling blood calcium level. So this is the mechanism which happens when there is a falling of the blood calcium level. The main hormone involved is the parathyroid hormone that is secreted by the parathyroid gland. Then another mechanism is if the homeostasis is maintained, but if there is any rising of the blood calcium level above this homeostasis level, that act as a stimulus for the thyroid gland, and that thyroid gland in response to this stimulus which releases the calcitonin, and this calcitonin which causes the opposition of this stimulus, that is which causes the decrease in the blood calcium level, and also that causes the attainment of the homeostasis, that is blood calcium level 10 milligram per 100 ml. So the calcitonin which by the different mechanism, that is first on it stimulates the calcium 2 plus deposition in the bone, that is excess calcium in the rising blood calcium level is deposited in this bone by the osteoblastic stimulation, and also it act on the kidney and which reduces the calcium 2 plus uptake in the kidney, and by these two mechanisms the calcitonin which decreases the blood calcium level and declines to set point, and the homeostasis for the blood calcium level is achieved. So these are the mechanism when the calcium level of the blood is raised. The major hormone involved is the calcitonin by these two mechanisms, by action of the bone and by action of the kidney, which decreases the calcium level. And here uh, the stimulus is falling on the blood calcium level. The main hormone involved is the parathyroid hormone to increase the blood calcium level. To decrease the calcium level, calcitonin is the main hormone. So that's all about um, the calcium metabolism. So the normal calcium metabolism is we describe very well. So to remember that, we have to remember that picture, that is the calcium metabolism picture in our mind. So let's discuss about the um, the functions of the calcium. Okay, then the functions of the calcium, then only we can remember or understand more about the deficiency disorder. So the functions of calcium, which includes the formation of bonds and teeth, the calcium and phosphate, which are the major constituents of the bond. So it results in the formation of bone and teeth. So if there is any impairment of the calcium metabolism or calcium deficiency, which results in the bone deformities, and also there will be delayed dentition will be there. So that is the first function of the calcium. Then we have the muscle contraction. The calcium, which results in the muscle contraction by the release from the synaptic vesicles, and then it also results in the coagulation of blood, and also it causes the neuromuscular excitability and signal transduction. And another is the integrity of the cell membrane by maintaining the resting membrane potential. So these are the functions of the calcium. Then what are the recommended daily allowance for the calcium? This is an important 1 mark question, that is recommended daily allowance of the calcium in different age groups. In the preterm neonates, it is 150 to 220 milligram per kilogram per day. And in the term neonates, it is 200 milligram per kilogram per day. In the 1 to 12 months of age, that is in the infancy, it is 250 to 500 milligram per kilogram per day. And the 1 to 18 years of age, it is 600 to 800 milligram per kilogram per day. And the lactating and pregnant mothers, the calcium requirement is increased. So therefore, the recommended daily allowance is 1,300 milligram per kilogram per day. So then the richest sources of the calcium, which are the milk and milk products, eggs, fish, and green leafy vegetables, which are the richest source of the calcium, and also almonds, peas, and sesame seeds. And the two main forms of calcium in the supplements are calcium carbonate as 40% and calcium citrate as 21%. Calcium carbonate is more commonly available and is both inexpensive and convenient due to its dependence on stomach acid for the absorption. Calcium carbonate is absorbed most efficiently when taken with the food. And the calcium citrate is absorbed equally well when taken with or without the food. Then what are the normal values of the calcium? Total serum calcium is about at 8.5 to 10 milligram per deciliter. Ionized calcium, in that total serum calcium, that is the ionized calcium, that is free calcium, which constitute about the 14%, and the protein bound, that is either it bound to albumin as 90% or globulin 10%, it contribute to 40%, and the majority binds to albumin, that is 90%, and the complex salts like 12% citrate, lactate, phosphate, and bicarbonate. So these are the normal values of the serum calcium. Then we also describe about the metabolism of the calcium in that picture. So once again, maintenance of normal level of calcium. The kidney, most of the filtered calcium is reabsorbed in the kidney. And factors which affect in the calcium reabsorption in the kidney, which are the which causes increased calcium are the parathermal. As already we discussed in that if the calcium level in the blood is decreased, it acts as a stimulus for the parathyroid gland and produce the parathormone. And then calcitonin, which decreases the calcium level. Then vitamin D, thiazide diuretics, and volume depletion, and which causes decrease is volume expansion, increase the sodium intake, and mannitol and furosemide. The maintenance of serum calcium concentration, which requires the adequate intake of the calcium, adequate intake or availability of the vitamin D, because it causes the increased uptake from the intestine as well as from the kidney, and the parathormone secretion, calcium sensing receptors, and signaling. So these are the maintenance of serum calcium concentration prerequisites. And also from the intestines, major source of calcium is dietary, but only 50% is absorbed. Increased absorption happens in the case of if there is an increased body needs vitamin D, proteins, lactose, acidic medium, which causes increased absorption, and decreased absorption in the case of the vitamin D deficiency, because vitamin D which causes the increased absorption from the intestine. If there is any vitamin D deficiency, which results in decreased absorption, and also oxalic acid, because the free calcium is not available, because the calcium binds with the oxalic acid to form the calcium oxalate, and it excreted through the urine. So also the absorption is decreased by the presence of oxalic acid. Then phosphorus, dietary fibers, excessive salts, which results in decreased absorption of the calcium from the intestine. And the calcium sensor receptor, it is the receptor present on the parathyroid gland, thyroid gland, and the kidneys, which senses the changes in serum calcium levels and allow these organs to respond to these changes. So this mechanism metabolism, which is all we also discussed earlier, that is there is hypocalcemia that acts as a stimulus for the parathyroid gland, and it increases the secretion of parathyroid hormone, which causes the act on the bone and which causes the increased bone resorption, and also which act on the kidney and which causes increased calcium reabsorption, and and also in the kidney there will be production of the 125 dihydroxycholecalciferol, that is vitamin D3, active form of the vitamin D, and act on the intestine and it causes increased absorption of calcium, therefore the plasma calcium level is increases. This is the mechanism which happens when there is hypocalcemia, so this all should be kept in mind. Then about the hypocalcemia, that is our main topic. That is a short note as hypocalcemia in the children. So definition of the hypocalcemia is serum calcium level that is less than 7 milligram per deciliter, or ionized calcium is less than 4 milligram per deciliter. That is called as the hypocalcemia. That is total serum calcium is less than 7 milligram per deciliter, or ionized calcium is less than 4 milligram per deciliter. That is called as the hypocalcemia. That is definition. And what are the etiology? That is what are the causes of the hypocalcemia? There are four different causes, four headings are there. That's neonatal causes, hypoparathyroidism, vitamin D deficiency, and others. In the neonatal, the infant high phosphate formula, infant of diabetic mother, and prematurity all have the hypocalcemia. And another heading is hypoparathyroidism. That is, if there is an aphasia or hypoplasia of the parathyroid gland, Digeorge syndrome, and parathyroid hormone insensitivity, and post-surgical or the radiation, they have the hypoparathyroidism that in turn results in the decreased serum calcium level of the hypocalcemia. And if there is any vitamin D deficiency, or it is either acquired or inherited disorders of the vitamin D metabolism or the vitamin D resistance, that all results in the hypocalcemia. And others, like in the case of hypomagnesemia, hyperphosphatemia, metabolic alkalosis, and drugs like furosemide and phenytoin, all these produces the hypocalcemia. So these are the four major headings or the causes of the hypocalcemia. Then causes of the transient hypocalcemia, that is not permanent hypocalcemia, it is only for a certain period. That is due to severe sepsis, burns, acute rheumatic fever, and extensive transfusion with the citrated blood. So these are the causes for the transient hypocalcemia. That is severe sepsis, burns, acute rheumatic fever, extensive transfusion with the citrated blood. Then next is the next heading of our essay is the clinical features of the hypocalcemia. The features in the older children are in the features of the hypocalcemia newborn we will discuss later, and here it is the features in the older children, which include carpopedals and muscle spasm because of the decreased calcium level, then tetany and laryngospasm or the bronchospasm, paresthesia and seizure or irritability, depression or psychosis, intracranial hypertension, prolonged QT interval and arrhythmias, respiratory arrest, and chronic malabsorption. So these are the features in the older children. And then the signs of the latent, that is, these are the symptoms and the signs of the latent tetany pictures, choastic sign, that is twitching of the orbicularis oculi and mouth, elicited by the tapping on the facial nerve anterior to the standard process. That is called the choastic sign. That is usually happens as a sign in the case of hypocalcemia. Then another sign is the Trocho sign, that is carpopedal spasm elicited by inflating blood pressure cuff above systolic pressure for 3 minutes. That is, we tie the blood pressure cuff on our arm, and it inflated above the systolic pressure for 3 minutes, and there will be presence of the or precipitation of the carpopedal spasm because of the hypocalcemia. That is the Trocho sign. Then how will you diagnose this condition? By the total and ionized serum calcium levels we should look for. If there is any decrease in that, it is an indicative of the hypocalcemia, less than 7 milligram per serum total calcium, and also decreased ionized calcium less than 4 milligram per deciliter, that is indicative of the hypocalcemia. Then only unbound calcium is biologically active, that is free calcium is biologically active. If ionized calcium levels are not available, total serum calcium should be corrected for albumin concentration using the following formula. That is, corrected calcium is equal to 0.8 into 4 minus albumin plus total serum calcium. Then this is the So this is the approach to hypocalcemia. This is the flow chart. അതായത് ഏതൊരു എക്സാമിനും നമുക്ക് അറിയാവുന്ന ഫ്ലോ ചാർട്ട് ഏത് വരയ്ക്കുമ്പോൾ ഏറ്റവും കൂടുതൽ മാർക്ക് സ്കോർ ചെയ്യാൻ ഭയങ്കര എളുപ്പമായിരിക്കും. സോ this is the approach towards the hypocalcemia. That is hypocalcemia, which means low serum calcium. That is total serum calcium is less than 7 milligram per deciliter, or the free or the ionized serum calcium is less than 4 milligram per deciliter. The correct four levels of serum albumin measures ionized calcium. First, we have to look for the total serum calcium, and then we have to monitor the ionized, measure the ionized calcium. And if the ionized calcium is normal, there is no action should be taken. And if the ionized calcium is low, we have to check further. We have to check for the serum phosphate. And the serum phosphate, if it is elevated, we have to do the renal function test. And if the renal function test is abnormal, it is indicative of the chronic renal failure. And if the renal function test is normal, it is indicative of, we have to look for the serum parathyroid hormone. There is no problem with the kidney. Therefore, the serum parathyroid hormone, if it is normal, we have the causes like urinary calcium or creatinine ratio, then familial hypercalciuric hypocalcemia. Then if the serum PTH is low, it is due to hypoparathyroidism, the hypocalcemia happens. And if the serum PTH is high, it is due to pseudo hypoparathyroidism, which results in the hypocalcemia. So if the serum phosphate level is low or normal, we have to look for the X-ray of the wrist or serum alkaline phosphatase. And if it is fine that the X-ray evidence and the serum alkaline phosphatase, which is increased in the case of rickets, if the rickets is present, if there is a response to oral vitamin D, it is known as, it is taken as nutrition request. That is, it is response to normal vitamin D, oral vitamin D, that is a nutrition request, and managed according to that. And if there is no presence of rickets on the radiological evidence, the vitamin D3 levels, or we have to check for the vitamin D3 levels and magnesium. If normal 125 dihydroxy vitamin D3 is there, if normal, that is vitamin D3 levels and magnesium levels are normal, we have to look for the 125 dihydroxy vitamin D3. And if this 125 dihydroxy vitamin D3 is low, it is vitamin D dependent rickets type 1. And if the 125 dihydroxy vitamin D3 is high, it is vitamin D dependent rickets type 2. That is because of the endocrine resistance to 125 dihydroxy vitamin D3. So these are the approach towards low serum calcium, to look for the causes for the hypocalcemia. Then what is the treatment for this? So we first we write a definition for the hypocalcemia, then about the etiology, the four major headings for the etiology. Then we have the clinical features, that is symptoms and signs, Chostek signs and Prosher sign. Then we look for the clinical examination and approach towards the hypocalcemia. Then we have to go for the treatment of the hypocalcemia. It is classified into two, that is treatment of the symptomatic hypocalcemia and the treatment of the asymptomatic hypocalcemia. In case of symptomatic hypocalcemia, a IV bolus of 2 cc per kilogram of the calcium gluconate, 10% over 10 minutes with the cardiac monitoring should be administered. And that is followed by the continuous IV infusion of 2 cc kilogram per day, titrated to calcium levels monitored 12 hourly. Then once serum calcium level is normal by this administration, decrease infusion rate to 50% on day 1 and 38% on day 2. Then after that, oral calcium supplements, that is 50 to 75 milligram per kilogram per day of elemental calcium is started, continued to maintain serum calcium level in low normal range. The calcium and phosphate levels monitored monthly, and urinary calcium or the creatinine ratio 3 monthly to prevent the hypercalciuria. So this is the treatment for the symptomatic hypocalcemia. The next is the treatment for the asymptomatic hypocalcemia. That is, we have to give continuous IV infusion 2 cc per kilogram per day, titrated to calcium levels monitored 12 hourly. So in this, we do not have to give the bolus for the IV bolus for the calcium. We have to directly infuse continuous IV infusion 2 cc per kilogram per day, titrated to calcium levels monitored by 12 hourly. Once serum calcium is normal, decrease infusion rate to 50% on day 1 and 38% on day 2. This is similar to that is the further steps of the symptomatic hypocalcemia, except that first step. Then, or after that, oral calcium supplements 50 to 75 milligram per kilogram per day of elemental calcium is started. Continue to maintain serum calcium in the normal low range. In infants with the hypocalcemia secondary to magnesium deficiency, these are the management options. That is intramuscular 50% magnesium sulfate solution, 100 milligram per kilogram, that is 0.2 milligram ml per kilogram per dose is required. 2 injections, 12 hours apart. That is second dose to be given after magnesium levels, followed by 3 days oral MgSO for 0.2 ml per kilogram per day once daily. Then for treatment of the chronic hypocalcemia due to the PTS deficiency or resistance, we have to give the calcitriol 50 nanogram per kilogram per day in 2 divided doses. So that is all about the hypocalcemia. Then we have a look into the hypercalcemia. That is also act as a short note. That is what are the hypercalcemia, what are the clinical features? Then hypercalcemia, the definition is the serum calcium level that is greater than 11 milligram per deciliter is called the hypercalcemia. Hypocalcemia is less than 7 milligram per deciliter. Here the serum calcium level greater than 11 milligram per deciliter is called the hypercalcemia, and it occurs when the rate of calcium entry into the extracellular fluid exceeds kidney's capacity for its excretion. Therefore, there will be accumulation of the calcium. There will be hypocalcemia. The mechanism are increased absorption of calcium from the intestine, increased release of calcium from the skeleton by the bone resorption, and decreased excretion of calcium from the kidney. So these are the mechanism which contributes to the hypercalcemia. Increased absorption from the intestine, increased calcium resorption from the skeleton, and increased excretion of the calcium from the kidney. Decreased excretion of the calcium from the kidneys, there will be accumulation of the calcium that results in the hypercalcemia. And the causes are in neonates, neonatal primary hyperparathyroidism, secondary hyperparathyroidism, then familial hypercalciuric hyperkalemia, because parathyroid hormone which increases the calcium level, therefore the hyperparathyroidism which causes the hypercalcemia, familial hypocalciuric hypercalcemia, Williams syndrome, hyperphosphatasia, and idiopathic infantile hypercalcemia, then excessive supplementation of the calcium. These are the causes for the hypercalcemia in the neonates. In the older children, hyperparathyroidism, that is parathyroid adenoma, autosomal dominant hereditary hyperparathyroidism, which in turn causes hypercalcemia, and malignancies like non-Hodgkin's or Hodgkin's lymphoma or neuroblastoma because of these tumors or the malignancies which will result in the hypercalcemia, and the granulomatous disease like sarcoidosis, tuberculosis, Wagner's disease also results in hypercalcemia, and others like hypervitaminosis A or D, thiazide diuretics, and thyrotoxicosis also which results in the hypercalcemia. Then what are the clinical features of the hypercalcemia? Or in the older children, it causes non-specific abdominal pain, muscle weakness, neuropsychiatric symptoms, polydipsia, the polyuria, and that results in the dehydration. And also there will be nephrocalcinosis, nephrolithiasis, and renal impairment because of the hypercalciuria. Then in the infant, there will be feeding difficulty, vomiting, failure to thrive, irritability, and hypotension. So these are the clinical features of the hypercalcemia. Then what are the treatment? Coming to the treatment, first is the hydration and sodium diuresis, because in the case of hypercalcemia, there will be polydipsia and polyuria results in dehydration. So we have to correct this dehydration by the hydration and sodium diuresis. That is IV isotonic saline 1 to 1.5 for maintenance, and the sodium diuresis with the furosemide 1 milligram per kilogram 12 hourly we have to give for correction of the dehydration. Then we have to decrease the GI calcium absorption by decrease dietary calcium to 1/4 of the recommended daily allowance. So there will be decreased GI calcium absorption, and also decrease in the stock of vitamin D, that is sunblocks used to limit cutaneous vitamin D synthesis, and oral prednisolone 2 milligram per kilogram per day, a maximum of the 60 milligram per day should be required for the decreased GI calcium absorption. Thereby we have to decrease the blood calcium level. Then inhibition of the bone resorption, that is we have to supplement the bisphosphonates like a pamidronate 1 milligram per kilogram per day, maximum 60 milligram per day, infused over 4 hours every 2 to 3 days. And also if there is any if there is a severe form of the hypercalcemia, we have to go for the dialysis. So these are the management or the treatment options for the hypercalcemia. So that's all about the calcium metabolism. and calcium related topics which are usually asked in university exam. Okay, thank you.